Continuing education credits for physicians and other healthcare professionals are provided by VCU Healthcare Continuing Education. Check out cribsiders.vcuhealth.org for more information. The Cribsiders podcast is for entertainment, education, and informational purposes only. The views and statements expressed in this podcast are solely of those of the hosts.
Welcome back to the Cribsiders. I'm Chris the Chew Man Chew. I'm joined tonight by my friends, co-host Sam, as well as our producer Vishak. Say hi, guys.
Hey, Chris.
Hello.
Our guest tonight is Dr. Janetta Arellano to discuss ADEM, which I guess we'll talk about what that stands for as well. But first, Sam, remind us what our show's about.
Yeah, absolutely. So we are the Pediatric Medicine Podcast. We interview leading experts in the fields to bring clinical pearls, practice-changing knowledge, and answering lingering questions about core topics in pediatric medicine.
We have a fantastic conversation with our guest, Dr. Arellano. Dr. Janetta Arellano is a bilingual pediatric neurologist specializing in neuroimmunological disorders. She earned her degree from the University of Washington School of Medicine, completed her pediatric neurology residency at University of California, Irvine Children's Hospital of Orange County, and now practices at Chalk Children's Hospital, part of Rady Children's Health. Her clinical research focuses on neuroimmunological conditions, including pediatric onset multiple sclerosis, acute disseminated encephalomyelitis, or ADEM, and anti-NMDA receptor encephalitis. She teaches us about the red flag symptoms that should raise concern for ADEM, the important diagnostic steps and initial management that's involved, as well as the potential long-term outcomes.
You put a lot of tongue twisters in that bio. Good thing you're the one who wrote that, so.
I did. That was challenging. So after this episode, we hope you will be adept at recognizing and treating ADEM.
Let's not be inflammatory about the details on that one. All right. Hello, Dr. Arellano. Thank you for coming on the show.
Thank you for inviting me.
First, because we're sort of an informal group, I'd like to ask, is it okay if we call you by your first name as we have our discussion?
Yes, of course.
Excellent. So is Janetta, is that right?
Janetta, yes.
Janetta. Okay, fantastic. So for our listeners to get to know you a little better, could you describe yourself a little bit in a couple sentences and maybe something outside of medicine you like to do?
Of course. So I'm a bilingual pediatric neuroimmunologist. I'm passionate about compassionate care, connecting with families from all backgrounds, exploring the world and also our national parks with my husband. And we're also preparing for our first child. So a lot of exciting things to come.
Excellent. Well, congratulations ahead of time on that. So I find it interesting. So you introduce yourself as a bilingual physician, and something we have in my branch of Kashik hospitals is we have this language concordant care that we try really hard for our patients. Are you able to speak a little bit to, how you view being bilingual is in your general day-to-day practice?
Yeah, of course. So I'm bilingual in English and Spanish. And so the demographic that I practice in, we have a large population of Spanish-speaking patients. So it works really well with the surrounding area and family. So we do have a robust interpreter program here as well, live person and also video and audio available for non-speaking medical staff, and also for other languages that are in this community. And so I found it very valuable to be able to speak two languages, and it's also helpful for our families that feel a connection with their provider. And so especially with the complex neurological conditions that I have to explain to families, it's helpful speaking in their own language.
Absolutely. Very cool. Very cool.
So this is a question that I feel is very impactful towards me during my training as well as now in my practice. So Janetta, I was just wondering, what was your favorite failure throughout basically your life, and what did you learn from it?
Yeah, so actually it's one that's fairly recent in my current practice. I do have a patient who's a young girl who couldn't find a diagnosis for her complex neurological symptoms and non-neurological symptoms. And so we tried really hard at our institution and with our team. And so I had discussed with other colleagues outside of our institution, including the NIH, who have provided a lot of collaboration, and so who have helped move the case forward. And so the important thing about that is that, sometimes you want to solve it all, know it all, but it's also understanding what your limits are and when to seek help. And so always have the patient at the center of the care, because that's the most important thing.
You're speaking to a bunch of generalists, so we feel very comfortable calling for help all over the place. But yeah, I can imagine also for all of our subspecialty listeners who are there, you do not need to know everything, but calling for help and making this a team sport sounds like the way to go and take care of patients. So I love that.
Mm-hmm. Definitely.
We've all been there. You walk out of a patient's room and need a focused differential and management plan now. Sanford Guide, known around the world for its much-loved antimicrobial therapy guidance, has covered you with a new app for pediatric acute care. There's no need to find an empty workstation. On your phone, you can search over 500 pediatric acute care topics in seconds. What you get isn't bulk or filler, it's streamlined, clinically nuanced guidance that's continuously updated by experts from the leading children's hospitals. This isn't an encyclopedic reference to scroll endlessly, and it's not an AI-generated summary. Every topic is intentionally written in a succinct, high-yield format from the start. So the Sanford Guide to Pediatric Acute Care app gives you exactly what you need at the bedside. Clear diagnostic reasoning paired with practical, evidence-informed therapeutic guidance. Search for Sanford Guide in the app stores, and Cribsiders listeners can get 20% off the already very moderately priced yearly subscription directly from sanfordguide.com. Go to sanfordguide.com and use the code Cribsiders at checkout.
We have a case from Cashlack Children's. So we have Adam Mylan. He is a 9-year-old previously healthy patient who presents to the emergency room with confusion and difficulty walking that started today. He started complaining of headaches a few days prior and had a few episodes of vomiting as well, which parents attributed to a stomach bug. Mom reported that Adam had a cold with a runny nose, cough, and a mild fever about 2 to 3 weeks ago, which is since resolved. Parents state that this morning, after waking up, he started to slur speech and started bumping into walls, which made them come to the ER. So based on this initial presentation that Adam had, what are the kind of concerning signs and symptoms that are present, and what further history would you want to get?
So the most concerning is a neo-onset speech disturbance with the dysarthria and the gait disturbance that started it acutely this morning. It's most concerning given that the patient was otherwise doing okay except for the last few weeks. Also, there's other symptoms that I worry about, increased intracranial pressure and encephalitis, the headaches and vomiting, and the infectious symptoms that predated this presentation. At the neurologist, I worry like the stroke is on the differential, but I know we talked about it later.
No, that's what I was going to bring up. I was going to say, like, this seems like a bad neurologic problem, right? Like, there's neurology symptoms. What should we do? So is there anything from a physical exam standpoint that is kind of leading you to the right or wrong direction?
So, yes, from a physical exam, what are the vital signs? So is there any concern for dysautonomia or elevated blood pressure? Is a patient still febrile? Does the patient look toxic? And what's the mental status of the patient? Because you had mentioned there's probably some confusion as well, change in mental status. So what is that presentation now? And then, of course, since I mentioned infection, is there meningeal signs and focal neurological deficits given the gait disturbance? What does it look like? Is it weakness or cerebellar signs as well?
So this patient that we have in our case today is a 9-year-old. Can these types of symptoms present at a younger age? And if so, what types of red flags would we see there? Because, we maybe have some children younger who aren't quite as verbal or won't be speaking full sentences. So it might be a little harder to detect something like slurred speech, or may not be fully, even younger, they may not be walking super great to begin with. Like, what are some other things that we may need to be paying attention to as we're examining patients and taking history?
So listening to the family. So what is the child typically doing at their baseline? So developmental stage is so important. So what's their developmental status that predated this? Are they on track? Or did they veer off completely at this acute presentation? Or have they already been struggling with gait, for example? And any verbal, did the patient have any like speech delays or verbal issues prior? That can help. Biggest thing is like the patient's prior baseline is important. So are they neurotypical? Or do they have any other medical diagnoses?
So we did the classic thing, classic board question piece by giving you, this kid had some URI symptoms and maybe a fever, maybe a cough a couple weeks ago. I feel like that's always hard because it's from a board question standpoint, they know to ask that, but we always have to remember to ask that in actual life because these patients came in with like, acute neurologic deficit that you're worried about. Like, who's remembering to ask about the fever a couple weeks ago or the URI symptoms? But having said that, we are going to focus on those types of things here in this case. So I am going to ask you that question, but just for all of us to remember. So there's a big broad differential for neurologic symptoms after kind of these things, whether it be, we'll call it a viral URI. And what is the differential diagnosis that you're considering? What are you thinking about as you hear those, a couple weeks ago, I might have had some cough, cold, congestion symptoms?
Right. So first, I think, is there acute infection of the central nervous system, given those prior history? Is an immune-mediated response triggered by infection, given it's been 2 to 3 weeks afterwards? Or are we exacerbating an underlying disorder that based on the prior infection symptoms too? So I always like to ask too, like the infection symptoms, but also like any recent travel, other exposures as part of like my history, because that, like you mentioned, it's so important and sometimes it's missed. That can play a big role in the patient's diagnosis.
And so as you were talking about, initially while we were talking about the patient, you're like, you're worried about meningitis, things like that. What are some other big differentials that we really need to keep in our back pocket to be like, all right, this is something that I really need to really look at closer as we continue to work up the patient?
Mm-hmm. So I had mentioned already like vascular. So given the acute onset neurological symptoms, we want to make sure that we don't miss like stroke or vasculitis that are more acutely. And another category, given that it's like post-infectious, some of our neuroinflammatory disorder and autoimmune disorders too, like ADEM or other demyelinating diseases too.
Which would you say is like most common? Like, so I know we can have a tendency to talk about zebras, but what, like, I mean, in a couple of weeks to months, like viral season is going to start on us again. And I'm going to see a lot of kids with viral syndromes and then even post-viral syndromes. I assume that might be the most common, or, especially, say, I work in a sickle cell clinic, like you might have some patients, obviously stroke might be higher in my differential. Like what are the things that I really need to keep high, and how do I triage that down?
Correct. So if it's viral syndromes, and then maybe it could be related to the acute infection, the patient may just feel unwell, may have conditions where maybe it's not necessarily like particular neurological, but may just not feel well. So I guess those are most important. Like you have encephalopathies or like change in mental status because you're sick, and then you can progress as like is the I didn't ask earlier, but is there concern for like seizures, other abnormal movements part of this patient that you can add on? Because some of the febrile illness can lead to seizures, and especially if it's a younger child, you can have a provoked seizure, provoked neurological symptom from an illness too. That's self-limited. And so as you go higher into like more rare conditions, then you kind of did your initial evaluation, but there's more suspicion that something's going on. So that's when you go through like the more rarer zebras of what this could be too.
So I guess in the case of Adam, we did our basic, we did our physical exam and the vitals didn't show really a fever. Maybe we're a little bit less concerned that this is an acute meningitis picture. And then at this point, you mentioned previously about possible ADEM with regards to the previous fever, runny nose, cough 2-3 weeks ago. Would you be able to explain that for us a little bit and kind of explain a little bit about the pathophysiology?
Sure. So ADEM is acute disseminated encephalomyelitis, which is autoimmune demyelinating disease of the central nervous system. Usually occurs in children, but also can you see in adults, but typically after a viral infection and in rare situations after immunizations. And it usually presents acutely, so multifocal neurological deficits and also encephalopathy, which is the mental status changes that Adam experienced. So for the pathophysiology, first is a triggering event. So is it the viral infection or vaccination that triggers an immune system response? And so against the antigens from the actual infection. And then you have molecular mimicry. So either the viral bacteria antigens share the structural similarities with the myelin protein, such as like myelin basic protein, and the immune response mistakenly cross-reacts with that central nervous system myelin. And then you get the immune activation. So you have your lymphocytes, particularly the T cells that infiltrate the central nervous system, releasing inflammation, which includes the cytokines. And also you have other cells, which is the B cells, that then produce the antibodies in some situations, like with myelin oligodendrocyte glycoprotein antibodies. And so because of that, then you have inflammation and demyelination that occur. And then this is how you have the presenting symptoms from the inflammation and demyelination. And so it could be typically around the small veins and venules. And it's disseminated, meaning it's in multiple locations. And it's typically a one-time event, monophasic. So I guess if you think of it as the immune system overreacts and then after fighting an infection and then mistakes the brain's myelin for the virus and then causing that temporary widespread demyelination inflammation.
That's awesome. So this sounds like an autoimmune or at least immune-based demyelinating disorder. I know that we have lots of immune-based demyelinating disorders. And so I was wondering if you could kind of talk about list kind of the differential diagnosis or at least that group of diseases. And then we can kind of understand where this falls when we think of differential diagnosis, if that's okay.
Mm-hmm. Yeah, of course. So there's a broad range, like you said. I think most people may recognize like multiple sclerosis as one of the demyelinating disorders, which is different from ADEM, because ADEM is usually a one-time event, monophasic, which is multiple sclerosis. We don't know the exact etiology, but tends to have relapse or progression. And then there's another big group category that we're learning more and more about, which is the MOGAD, which is a anti-MOG demyelinating disorders. And so it's antibodies towards the myelin oligodendrocyte glycoprotein. And so within that, you do have ADEM. So basically what unites the MOGAD conditions is that you have MOG IgG antibodies positive. So other than ADEM, you can have optic neuritis, inflammation of the optic nerve, also transverse myelitis, which is inflammation of the spinal cord, pediatric onset, like neuromyelitis optica spectrum disorder, which you can have antibodies towards MOG or antibodies to alkaline 4 because it can look like that as well. And then another condition that we've been seeing more and more institution is the cerebrocortical encephalitis. So it's part of the MOGAD spectrum, but seen more in pediatrics. So usually it can present like stroke-like symptoms or seizures, but it's mainly predominantly affecting the cerebral cortex.
So just to follow up, just to make sure I understand. So it sounds like MS or multiple sclerosis is one piece. And then there's the anti-MOG or anti-MOG group of disease processes, which then include a differential diagnosis where ADEM falls along with things like optic neuritis, NMO. It's NMO for anti-MOG NMO, not anti-aquaporin NMO. And then this new disease process that I didn't know before, which is, can you say that one again? Cerebral...
corticoencephalitis.
Corticoencephalitis. Does that make sense? Or is one of those not in the anti-MOG group? So I just want to make sure. It sounds like MS and then anti-MOG is kind of how I'm getting this. Is that correct? Or is there another one that should be kind of to the side of that umbrella term?
So another side to is the neuromyelitis optica spectrum disorder as well. So MS, MOGAD, and then NMO is D.
Gotcha. And NMO, that's just the NMO that's aquaporin for NMO, right? It sounds like there's two NMOs, one that falls in the anti-MOG and one that's separate.
Correct. Mm-hmm.
Okay. I think I got that. Anyone who doesn't, feel free to listen to this again and again for the last 15 seconds and see where we are.
Rashad's going to put that all in the show notes. He's going to clarify it. We'll go. This is a good infographic, maybe.
Exactly. This is a nice flow sheet to just understand where those fall under. Because I think that's going to have to do a little bit with some of the antibodies that we may or may not see or send. And that's the reason why I ask. Because, so let's talk a little bit about workup, right? So this is a patient who now is acute neurologic symptom, post-viral situation. Let's say we're less concerned about infection, but maybe we should be because, just looking at a kid doesn't tell you whether you have, infectious encephalitis or not. What is the first workup that you kind of recommend that we do as this patient's in the emergency room?
So definitely head imaging. So neuroimaging would be important given the patient's presentation of the acute onset speech disturbance and gait disturbance. I would prefer brain MRI with and without contrast. However, I know it's challenging also in pediatrics because you need anesthesia. So sometimes we have to kind of balance what's priority. So if you foresee that's going to be a delay in getting brain MRI, then sometimes we'll move forward with the CT non-contrast, given that I mentioned like stroke is also in the differential. And so I would prioritize that. And of course, as you're waiting for those is getting your routine serum, urine studies for infectious and non-infectious causes, and also proceed with the lumbar puncture to further evaluate for infection and neuroinflammation. Part of the other differential is instead of like infectious or post-infectious is you always want to keep in mind like malignancy, neoplasm is also important because you don't want to disregard that as a red herring for the infectious symptoms.
Gotcha.
It takes heart to build bodies that break records. And over the last 6 years, a team of incredible healthcare professionals did what most people thought was impossible. They rebuilt the body of legendary Olympian Lindsey Vonn after a series of devastating injuries forced her into early retirement. Now, she's headed to the 2026 Winter Games, ready to break records once again. This February in Milan, Lindsey's team and the entire USA medical team will be wearing FIGS. You can rock their official uniform too. The new Team USA collection from FIGS is engineered with FiberX, their most durable fabric yet. FiberX is setting the new gold standard for high-performance scrubwear. It's lightweight, breathable, and ultra-resilient. And of course, the styles come in red, white, and blue. So, listeners, check out the limited edition Team USA collection and get 15% off your first order at wearfigs.com with code FIGSRX. That's wearfigs.com, code FIGSRX.
As we're getting these labs, what are some of the things that we may see, especially that may support our ADEM diagnosis? So in our serologies, am I going to see typical leukocytosis? Am I going to see what are the things? What are the things should increase ADEM on my differential?
Yeah, so on your stem studies, you could see leukocytosis, but you don't necessarily would see that. Perhaps some of your inflammatory markers would be elevated, like ESR, but sometimes it doesn't have to be. So sometimes in those routine studies, you may not see as much until you do the lumbar puncture, and then you'll see some abnormalities there.
Yeah, let's talk a little bit about, so what should we be ordering when we're ordering that lumbar puncture? Say I'm the emergency room doctor, I have some time, I'm going to get this LP. What tests am I sending?
So I definitely recommend getting high volume lumbar puncture. So definitely get 15 to 20 cc's of cerebrospinal fluid. That's important. And because there was concern, for me anyway, that there's could potentially be increased intracranial pressure, is getting an opening pressure and closing pressure. So that would be the first thing to obtain. And when in doubt, always obtain it because it may be helpful after the fact. And also getting the cell count with differential, protein, glucose, culture. In our institution, we have a meningoencephalitis panel, which is PCR of various infectious agents that can be treated or not be treated. So that's helpful to include. Also includes like HSV and other organisms too. Since we're worried about for neuroinflammation, then oligoklonobans can be helpful as well. That's like another non-specific marker of inflammation with that can be seen in some of the demyelinating disorders.
What specific patterns would you see on cell count as well as glucose for if you're concerned about ADEM as a diagnosis?
So you may see a mild pleocytosis. So you may see like a lymphocytic predominance, like the nucleated cells can be 20 to 50. And then you can also see mild elevation of protein as well. Glucose, it just varies. It can be normal. So that's what we typically see is most things we see the pleocytosis and the elevated protein.
And from a lumbar puncture perspective, we always are worried about doing something or giving something before so we don't screw up the lumbar puncture. You know, antibiotics is classically the one. Is anything going to mess up our lumbar puncture for a diagnosis of ADEM?
Not necessarily. So even if it's like infectious, you may not affect the CSF studies if it's done like shortly after antibiotic, and you may see some abnormalities despite that. But for ADEM in particular, it won't affect that.
Another question around the CSF is, I work in the ED off and on, through my training. I have come across the times when parents aren't exactly the most excited to say let their kids get a spinal tap because they hear the word spinal tap and you try to explain it and how important it is. Like it sounds like that's especially since many of the other labs and testing we may get may be less definitive, and maybe our CSF might be, besides the imaging, might be more gold standard. If a parent's like, I don't want the spinal tap, would it be reasonable to get the MRI, see where the result is, and then say, hey, this looks like it's looking towards ADEM. We really need the CSF to really make that definitive diagnosis. That's something that you foreseeably could come across?
Definitely. We do see it routinely. And so if there's no delay with the MRI, because also the MRI may be helpful to make sure that it's safe to do the lumbar puncture too. And so I think it's reasonable to wait if the patient is not looking like toxic appearing to you or decompensated quickly, because if there's an active infection, you want to make sure you treat it right away. And so that would be helpful with the cerebrospinal fluid studies. But it'd be reasonable to wait for the imaging.
And you said sometimes it may be reasonable to get the imaging before the tap to make sure it's safe. Are you talking about in terms of like herniation?
Correct, herniation, and also the lumbar puncture may affect may have some effect on your MRI findings too, especially if you're needing to get spinal imaging. And so if you want to kind of separate what's related to lumbar puncture versus what's the MRI findings related to the underlying condition, that may be helpful to obtain. And I didn't mention earlier, but some of the findings on exam or even history may warrant doing like full MRI neural axis, so brain, cervical, and thoracic cord as well, with and without contrast, especially in the younger children where we always need sedation, then we may consider doing those all together.
So for ADEM, we had a pretty robust child life team, so we were able to get the MRI done as well pretty seamlessly. And then we got the CSF studies. So in this case, What are you looking for in the imaging, in the MRI itself with regards to ADEM?
So MRI usually has like bilateral changes. So we have T2 flare hyperintensities, not only in the white matter, but also the deep gray matter. You can see that. You think of the lesions very fluffy, which is a stark difference from like multiple sclerosis lesions where like they're ovoid, well demarcated, and sometimes can be symmetric or not, but typically it's bilateral. Lesions typically don't have enhancement, but you can have that as well. So that's why it's important to get with contrast, because that can help differentiate with other conditions as well.
Now, you said that sometimes if MRIs are not possible, that you will work on getting the non-contrast CT. Now, is that just because non-contrast CT will help us rule out stroke? And would there be anything on CT that may indicate ADEM?
So the reason I said non-contrast CT is that if we worried for acute episode, making sure, especially, I didn't ask this earlier, but if it's been a long time, or if the patient's last known normal, which we ask this question a lot about, like stroke, has been several hours, we may see changes on CT non-contrast, but it doesn't necessarily rule out stroke depending on the timing. But the other thing is that for infections, is there an abscess causing these symptoms or infections again that you may see? It's always helpful to do with contrast if you worry for infection anyway, but potentially can you see a large mass or midline shift too? So those are the other things that I've been looking for on the CT non-contrast. I have lower suspicion for like a bleed or hemorrhage, which is helpful to see on the CT non-contrast. But the biggest thing I wanted to make sure is that there's no like herniation. Do we see anything large and abnormal or like a subacute stroke that you can see on the non-contrast?
Awesome. And I think, honestly, if this patient comes into the emergency room like this and say I'm the emergency room doctor, now I am not emergency room trained in any way, shape, or form, but I would probably get a non-con head CT. Hey, this kid's vomiting and they got weird neurologic symptoms. Like that's getting there. It's going to take me 3 days to get an MRI, but I'm definitely scanning this kid's brain before they leave my ER. So at least we'll find something, or maybe not, but at least we'll rule out some other things too. I did want to ask about the diagnosis. We talked about MRI, we talked about CSF, we talked about, having bilateral plaques, or at least not plaques, but, at least findings that are in the gray and white matter that's hopefully representing demyelination. We also talked about maybe a small pleocytosis and some oligoclonal bands. How do we physically make the diagnosis of ADEM? Is it just is this kind of a syndrome of things, or is there another test that actually confirms this per se?
So we had mentioned earlier about the antibodies, and so there are some ADEMs that may be related to antibodies, and so those we test, and I had mentioned in the serum. So for MOG IgG antibodies, you want to do serum testing to evaluate that. There is a criteria, both clinical and radiologic diagnosis from the International Pediatric MS study group. And so there's required clinical features. So it's your first polyfocal central nervous system event where you have multifocal neurological deficits. Also, encephalopathy is required. So if there's no encephalopathy, then you don't put it in, as a diagnosis of ADEM. So that includes like behavioral changes, your ultimate status, lethargy, irritability. So it's not explained by fever or other metabolic issues. And then you have your MRI criteria. So I had mentioned like it's large, poorly demarcated bilateral T2 flare lesions involving both the white matter and gray matter, plus or minus the gray matter. And usually lesions are acute or subacute. There's no prior evidence of demyelination. So this is where it falls like the monophasic course. So you will not see changes on T1 imaging. So if it's something chronic, you may see T1 hypointensities, which can be seen with multiple sclerosis. And then, like you mentioned, the CSF supported features, but it's not diagnostic. It just kind of supports the diagnosis with the mild lymphocytic pleocytosis and elevated protein. And definitely want to exclude other causes.
Right. And that makes sense. Infection being a big one there. For the anti-MOG antibodies, I'm just curious, do I just type in MOG into my EMR, or is there a specific couple, or is it a panel that you send out? How am I testing for anti-MOG?
That's a great question. So all the above, or one of the ones that apply. So my institution, they already have it as MOG, IgG. It's a send-out lab to Mayo Laboratories or AREP Laboratories. Quest also does it, but it's also dependent on how the testing is performed for more accuracy. So it's definitely more sensitive in the serum than the CSF. And so my preferred labs are Mayo and AREP. It comes as a single test, or you can do it as a panel. So there are pediatric autoimmune panels that you send out to Mayo, which includes a robust number of antibodies, including antibodies to aquaporin 4 as well. Or you can send it as a panel with just aquaporin 4 and MOG antibody as well. And so most important is how, like I mentioned, how the testing is run. So live cell-based assay gives you the more accurate diagnosis.
Yeah, one question I think we forgot to ask early on while we're talking about like pathophys and stuff like that is I was wondering what is actually the age distribution we're seeing with ADEM? Because can we see it at every age of life? But is there a peak instance? And it sounds like maybe our case might be sort of in the area of where we might see this most commonly.
No, that's a great question. So we tend to see it in both the children and adults. We do see a peak in children, that we see it more often than adults. But if an adult is presenting, you don't want to disregard that too.
I actually just had one more follow-up question on the labs first. It seemed like there are a lot of send-out studies that you were talking about. Generally, how long does it take to get those results back? Because it seems like it would be quite a fair bit of time.
That's a great question. So those send-out labs can take 1 to 3 weeks to come back. And it depends when the patient presents. Usually they come in the weekend, and then there's a little delay in sending out the studies. And then once you get it to the outside labs. And so you do have to make a clinical decision about treating your patient, probably without having these lab results back. But the importance of having these lab results back eventually is that it can potentially change your treatment post the acute period.
Okay. All right. So I guess at this point, we were able to get the lumbar puncture as well as the MRI. ADEM CSF studies point away from an infectious cause, and the MRI does show the bilateral lesions in the gray and white matter. A presumed diagnosis of ADEM was made, and we did send out the CSF. And he's admitted to the PICU for further treatment. So at this point, what's your general approach to initial treatment for ADEM?
So now that we ruled out infection, then the treatment is to give high dose IV corticosteroids. So typically we do IV methylprednisolone, 30 milligrams per kilogram, max 1 gram for 3 to 5 days. So that's first line treatment, and tends to respond really well, fairly quickly too.
Actually, my question is actually related to our STEM. So our patient was admitted to the PICU. Is that the most appropriate place for them, or is this a place that can be, or is this a patient that can be, if their vitals are stable, can they be managed and given steroids on a med-surg floor?
Yeah, that's a great question. So always where is the patient admitted to? So it depends on their current symptoms. So if they're otherwise not further decompensating, their vital signs doesn't show evidence of dysautonomia, or they're not having status epilepticus that they need to be treated further, then it would be okay to administer this treatment on the floor versus the pediatric ICU.
So say we're giving, 3 to 5 days, we'll call it 5 days, we're worried about this kid, say we'll give him 5 days of high dose corticosteroids. How are we following about whether we're improving or not, or we need to go to second line? Is this just all based on clinical symptoms? Do we repeat brain MRIs? What do we do for this case when we have to figure out when do we have to go to plan B?
Yeah, so definitely following the patient's clinical symptoms. So especially earlier on, if you don't see improvement or you see a progression, then definitely consider the inadequate response or more severe disease that you need to escalate treatment. Potentially repeating neuroimaging too soon may not give you the most optimal information. So a lot of it's based on clinical symptoms.
Awesome. So let's say that our patient still is maybe feeling a little bit better, but still can't walk straight, and that's obviously a major concern. What would be your next line? Do you think we should go to next line treatment, number one? And if so, what would that next line treatment be?
Yeah, so I think it's reasonable to discuss or consider next line treatment. And so based on the symptoms you presented that were so persistent, then you consider intravenous immunoglobulin. And so the dose is typically 2 grams per kilogram. You can divide it over 2 or 5 days, depending how well the patient tolerates it. Or if you can't go to the first line, which is the high-dose IV corticosteroids, you can always start with intravenous immunoglobulins as well. And if they have more severe disease, like they maybe have to be in the ICU, they're in a coma, ventilator, then you may consider instead plasma exchange instead, because that may have more immediate response.
And so it sounds like we're doing our kind of generic autoimmune immune dysregulation treatment, that there's no specific, like we don't have any anti-MOG, monoclonal antibody at this time. Of course, we're recording this, who knows what's going to happen in the next couple of years, but is that the general gist, that we're doing just our usual, like steroids, IVIG, plasma exchange, we're doing our usual stuff to try to just be anti-immune to the best of our ability?
That's correct. Unfortunately, yes, we don't have a specific anti-MOG treatment yet.
Not yet. Everybody who's a budding neurologist, this is the opportunity to do that. Awesome. Thank you.
Actually, that's my next one. Is there anything like in the pipeline in the future that may come along?
And so I think they're not specifically for MOG, but there's definitely other demyelinating disorders or specific treatments that can be considered. And so I know there are several clinical trials related to other neuroinflammatory conditions. So potentially.
So since it seems like prompt diagnosis of ADEM is pretty important to establish early treatment, are there any disparities that is noted with regards to leading to a delay in the diagnosis of ADEM?
Yeah, so I think most important is access to care. So it comes from just where, what's your patient population? So do the families come from areas where maybe it's rural, underserved communities that may not have access to even a children's hospital or pediatric neurologists or even neuroimaging like MRI? So if you don't have those resources, that can affect. Something that I commonly see too is like health literacy too. So the families aren't familiar with neurological diseases or disorders, then may delay seeking care for those reasons, because they may not recognize that these are like acute neurological symptoms. And language barriers, like I mentioned, that's why I kind of stress the importance of being bilingual too. So limited English proficiency can delay the recognition of encephalopathy. And how I think Chris mentioned too earlier is like, how do you know if the child has any deficits if they're younger, if you don't maybe developmental age, or it can be language too, that getting the history. So a lot can be observation and subtle signs that can be detected by the provider. And so that was from like a access to care and like from a family standpoint, but also provider level factor. So if your clinical suspicion is low for ADEM, given its rarity, or don't see it as much as your institution, or even non-neurologists may attribute symptoms to just infection or other causes like toxic causes like ingestion, or even psychiatric disorders. Misdiagnosis is also can affect delay in diagnosis and treatment, and also ordering these studies, like we mentioned, and there's a delay in sometimes getting some neuroimaging because of needing anesthesia, or the delay in getting antibody testing back. And so that's also important. From a system level, if you can't get like a diagnostic MRI urgently, like I already mentioned, like anesthesia plays a big role in how quickly you can get it in younger children, or if they're not cooperative, that can postpone the diagnosis, because I mentioned that the MRI is kind of the one of the most important things to obtain to know if it meets the diagnostic criteria for ADEM. And of course, like barriers to getting like coverage for the evaluation. So getting hospital evaluation or being transferred to institution where they have pediatric pediatric neurologist or pediatric neuroimmunologist, that may be challenging. And so I know at our institution we do get transfers from outside institutions where they, if they don't have a pediatric neurologist, they send them over to us. So that can be a barrier, just getting the patients to a location where they have the appropriate team.
Yeah, I mean, I wanted to highlight two of those things that you said. I mean, you said amazing, a lot more than two amazing, great ones. But we always are often talking about racial disparities and how those are affecting. But I think one of the big health equity barriers across the entire country is whether you have a children's hospital with sedation for a brain MRI. That is a humongous thing that we all take for granted in academic medicine, and I think, as you mentioned, plays a huge role. The other thing is, I was going to say, just for my own personal practice, acute encephalopathy for people who do speak a language other than English. We've had lots of delays in care because we're just waiting for the appropriate interpreter to find out that this person actually is encephalopathic, and we had no idea just because we couldn't understand them. And that goes a lot on us. But I think that's a really important point to highlight as well, assuming that's a main component here of this disease process. Actually, it's part of the diagnosis. You can't even be diagnosed without acute encephalopathy. So let me take that even higher. Awesome. Does anyone else have any follow-up questions for that? Otherwise, I was going to ask kind of a big picture one. Awesome. Okay. So we didn't really talk so much about like the natural history of ADEM. We probably should have done that earlier. What's the natural history of this general prognosis with and without treatment?
So overall, the prognosis is good. So most children do tend to recover within weeks to months. Some may have mild residual deficits. And so most commonly what I see and reported is like attention issues, behavioral changes, or maybe just subtle motor deficits, which can occur up to 20% of the cases. Having like more severe long-term disability is quite rare, especially if the treatment is given promptly. And so, and the other part that plays into the prognosis too is that most patients that have a follow-up MRI, most follow-up MRIs for these patients can have resolution of these lesions or even improvement within 3 to 6 months afterwards. So if you do have persistent new lesions, then you may suggest like a new or alternative diagnosis that you want to explore further.
And if you don't treat, for example, say we get caught up in the hold on, they came in on a weekend, I can't get sedation to Tuesday, I have my send out, I got the wrong diagnosis, or I'm coming back 3 weeks later, I have an anti-MOG antibody, and let's just say we've waited 3 weeks. What changes in our prognosis from that perspective?
So in particular, if you have like the MOG positive patients, they're definitely higher risks for relapse. So if not diagnosed and treated properly, then up to 50% may have a relapse. So they may have benefited from getting the initial treatment plus potentially like maintenance or long-term treatment to prevent further relapse. It's very rare to have like a multiphasic ADEM, which means you have recurrence of ADEM, like illness greater than 3 months after the initial episode. So you may have a new MRI lesion. So potentially the initial treatment may further prompt this. And so I think it's important to recognize and treat because you may have these alternative diagnoses or recurrence.
And just to clarify, when you're talking about the MOG antibody, right, that's because we have a spectrum of anti-MOG disease, and we thought this was ADEM, but it might fall, and we had a positive, MOG antibody, but it could have fallen under this spectrum of also including NMO, also including optic neuritis, also including the cerebral something encephalomyelitis that I should keep forgetting. Is that the understanding of why it could recur, because it's technically not ADEM that's really recurring based on its definition?
Correct. You could have other different phenotypes, correct, related to MOGA.
All right, what else you guys got? Otherwise, we can hit the last question. What do you think?
Yeah, I think we wrap up. Yeah. Chuck, it's up to you, man.
Yeah. So at this point, Adam's been discharged. His neurological symptoms have improved. So generally, what's the outpatient follow-up for patients and general counseling that you try to give after discharge?
So definitely want to follow up with the neurologist within 4 to 6 weeks after discharge, just to reassess how the patient's clinical symptoms continue to improve. May consider subsequent visits to kind of space out a little bit if the patient's doing well, but you want to make sure you monitor the neurologic recovery, how they're doing in school, because that's so important as well. Because I mentioned some may have a subset of minor symptoms, which can include like behavior and attention, and that can affect emotional health and also school performance. So making sure they have the adequate resources for school. Like here we have like a 504 plan or individualized educational program. So some things to consider. Besides just monitoring the neurological symptoms that you treated in the hospital, you may consider also repeating MRI 3 to 6 months afterwards, just to make sure that you have the correct diagnosis. So to make sure there's resolution or improvement of those lesions. And of course, if there's new or worsening of the prior symptoms, you may consider to reevaluate sooner and do neuroimaging sooner again. And so I had mentioned some of like the school issues too. So I do collaborate with like neuropsychology at our institution to do screening and evaluation for like attention, memory, processing speed that can be affected. And then if they have some residual like neurological deficits, referring to rehabilitation, so it can include physical therapy, occupational therapy, speech therapy as needed. And sometimes there may be, like I said, it may take a few weeks to get the antibody testing back. So that's when you also follow up to see if the patient ended up having MOG, IgG antibodies, or any other antibodies that may lead you to counseling families for like return precautions and also potential like long-term treatment too.
And I guess just one more question with regards to maybe outpatient treatment as well. It seems like maybe like a 5 to 7 day course of steroids, but do you ever send kids home on steroid tapers or that sort of thing for treatment at home and follow that up as well?
Yes, that's a great question. So typically I send home on an oral steroid taper. And so usually it's important to prevent early reoccurrence. And as you're waiting for these antibody testing to come back, it'd be helpful to continue that taper. So definitely want to educate family on the steroid side effects as well.
And how long is that taper usually? We always like to ask those questions.
Yeah, no, that's a good question.
Is it a 40, 30, 20, or is it 1 mg per kg, half mg per kg? How do you do it?
Yeah, so I do 2 mg per kg per day, max 60 milligrams per day, and then kind of taper or start weaning weekly. So probably be on it for around 4 weeks or so. And that's around the time that I'd be seeing these patients for follow-up anyway.
Awesome.
Well, I learned a whole bunch today. I think there was definitely many things that I didn't know. So this being sort of more rare and something I've never seen. But Vishak, he came up with this topic because he saw it when how long ago was this? He saw it in actual clinical.
Yeah, it was about 6 months ago. I saw it as a resident, and I just started writing it up right after I saw it. Yeah.
So, Janetta, I want to thank you so much for spending time with us this evening. I definitely learned a lot. I'm very sure that our listeners learned a lot. As we leave the episode, I would love it if you could give us some just last take-home points, things that you want to make sure our listeners take away from this episode so that we can make sure that we don't miss this diagnosis in the future.
No, thank you so much for inviting me again, and great to talk to you all. So I think the biggest thing is if you have any acute neurological symptoms, have in your mind that you're going to make sure you do neuroimaging as quick as you can. MRI is definitely preferable. And if safe to do, then lumbar puncture would be helpful as well, because then it can help you with your differential diagnosis. And then if the lesions of the clinical history fit with the diagnostic criteria for ADEM, then you want to make sure you treat as quickly as you can, because that can help with overall prognosis and hopefully prevention of relapse too. And then if things don't seem straightforward, then always have in your mind that always keep an open mind of other potential diagnoses too. So following these patients outpatient is also critical.
Excellent. And as we start off, I just want to see, is there anything you'd like to plug to our listeners? Is there a group, a website? Is there, want to make sure you want to really encourage people to go into pediatric neurology? Like, well, you can plug anything you want as we sign off.
I don't know. There's probably many websites, but for pediatric neurology, I was going to say it's a very fascinating field. It's growing a lot. We like to think a lot. So if you're someone that likes to spend time thinking and exploring further, then it's definitely a place for you. Especially, it's so broad what we see from birth to even adulthood. So broad range of developmental conditions and diagnoses. And so definitely an exciting time to be in this field too, with a lot of discoveries.
Well, thank you so much again for spending our time with us tonight, and happy to have you on.
Thank you so much.
This has been another episode of the Cribsiders.
It's
for the kids. Get our show notes and sign up for a bi-weekly Knowledge Food Formula Feeds newsletter on our website at www.thecribsiders.com.
We're committed to providing you with high-value practice-changing knowledge, and to do that, we need your feedback. So please subscribe, rate, and review the show on Apple Podcasts, or contact us at thecribsiders@gmail.com. Special thanks to our producer for this episode, Dr. Vishad Venkataraman, and our wonderful social media team, which is mostly Denise Cruz on X, Blue Sky, and Instagram. I've been Sam Mazer.
I've been Vishak.
And this has been Chris the Chi Man Chu. Thank you and good night. And for those who made it to the end, I guess my big question is, do you guys even listen or care whether I do these AA poems? I'm just still going to do them for now. Send message me, DM me on all the socials. Let us know. Do you want me to do this or not? I'm just going to do it. All right. It's called After the Storm. A cold that came and went away left Adam changed another day. His speech now slurred, his walk unsure, what seemed so simple now obscure. The myelin wrapped so neat and tight, now scattered, damaged, lost to sight. ADEM strikes when least expected, young brain suddenly affected. From virus to autoimmune fire, the body's own defense turns dire. On MRI, the lesions show where inflammation chose to go. With steroids strong, we fight the flame to help the damaged brain reclaim its pathways lost, its function clear, and bring back all the child holds dear. All right, see you guys. Bye.